Fistula Forum that has been prepared jointly with the Ministry of Health and Amref. So if you are coming for that forum in the right room, we'll hold the forum for 6-10 minutes, and we'll be hearing experiences on the intervention which have been done by the Ministry of Health with partners in this space to return smile to the women who have had fistula in their life as through their journey when they're bringing life to the world. So I want to take this honor to welcome the chairperson for this session, who is Dr. Serafina Mkua. Dr. Serafina Mkua is a public health specialist, and she had been trained as a medical doctor with a track record of experience of over 15 years in this country. Dr. Mkua has held various positions as a public health specialist throughout her career, and currently she's serving as a program manager for the maternal and child health services at Amref Health Africa. She also serves as a senior leader. She also serves in our senior leadership team at Amref Health Africa, and she holds a great passion in maternal and child health interventions. With her passion in maternal and child health intervention, she has led various efforts in fundraising to see that to improve the maternal and child health services in the country. And she had done this for quite a number of years, over 7 years, the ones that I remember. And she had done a number of initiatives for fundraising to support training of midwives in this country, but also to support availability of equipment for maternal and child health in this country. Dr. Mkua, in addition to the position that she has held at Amref, she also worked with Benjamin Mkapa, but she has also served as the president for Medical Women Association of Tanzania, MEWATA, where she also did a great job. With her passion and being a champion for maternal and child health, she'll be chairing our session today and moderate the session with the discussants for the next 60 hours.
To this important session, and I would also like to welcome you to our session, which is concerning fistula, with the theme of sealing the gap, empowering survivors with holistic fistula care for seamless community integration. So thank you so much, and to start with, I would like to welcome our keynote speaker, who will start with giving us some overview of the fistula globally and nationally. And this is none than our own, very own Dr. Florence Tem, who is a country director of Amref and the first Tanzanian to be a country director for Allocate Africa in Tanzania. Before having this position, she was the country director for Amref Health Africa in Ethiopia. And while she was in Tanzania, she rose up at different positions, including deputy country director, and then grew up to country director position. Before joining Amref Health Africa, Dr. Florence held various positions. At Ocean Road, she was the head of cancer prevention services, but she was also, she worked with Muhimbili National Hospital as a general practitioner and a researcher in maternal and HIV research, PMTCT clinical trials. Dr. Florence, she has had various leadership training, but currently she's also sitting in various board of directors in Guarantee Trust Bank, but she's also a board member of Stop TB Partnership in Tanzania chapter, and recently she has been a board member of Amref Health Africa in Canada. So,
Ladies and gentlemen, for me, this is really a privilege, apart from everything, also to let us to you know who Amref is in a very brief statement. I think Amref is not new to all who are in this room, so I'm not going to the history. I'm happy to see Dr. Brenda, hi, and many other. I can end up mentioning names of the people I'm delighted to see in this room. But Amref has been in existence for a couple of years, since officially in Tanzania since 1987. But since the time before independence, 1957, Amref started in East Africa. So Amref is actually East African born, but also raised in Africa. It's very much African-based organization. And now Amref West Africa in Tanzania is a Tanzanian-led kind of organization. How this happened? Amref used to have flying doctors coming to work in different places in the country, and also working with the Ministry of Health in terms of addressing a number of health issues. So today we are having our current strategy, which will run for 8 years. For those who happen to be in the launch session, we mentioned about it. But the second strategic platform is on the social determinants of health and emerging threats, that intersectionality with the health issues. So while we're addressing climate change, outbreaks, we are looking also on social determinants of health. But in the midst also of addressing primary health care as well, we're also looking at the social determinants of health. So I want to take this opportunity also to congratulate the Ministry of Health, the government of Tanzania, for dramatic and drastic drop down of the maternal mortality ratio in Tanzania. Whatever we mention about the figure, people ask, how did you do it? But I think we all know the secret behind how we did it, the deliberate efforts from all stakeholders, every partner, development partners, and the rest of us, but really by leadership of the Minister of Health and Dr. Makwani and colleagues. We really thank you so much for providing that leadership. So today we're talking about obstetric fistula. And I want to share an experience when back 2010, around there, 2010, 2011, I happened to fly with this little flying doctor's flight, 6-seaters little flight, went to Kibondo. And in the flight, I was together with the gynecologist and the surgeon. We went to Kibondo, and this was a campaign for fistula repair. And when we reached that hospital, there were a number of people waiting for us, and the women who came there for repair. But when we were there, while the doctors are preparing for the theater and everything, there was this man with the wife there, and this man came to me and asked me, "You people, are you sure you're gonna cure this? We have been hearing this in the local radio about people coming, doctors, etc. But we know this is a curse. It happened from when my wife took a while at the traditional birth attendant to deliver. We decided to take her to the hospital. Then the TDA said, mtaona. Mnampeleka huko, mtaona. So we know this is out of what the traditional birth attendant said, and that was then. So when in my talk there, I realized, so this fistula is really beyond what we think. It's not just in the hospital. It's something people to understand. So that awareness raising made them to come to hospital, but they're not sure what's going to happen. So that was one of the takes. Then when we were in the theater, we are with the surgeon, and I realized fistula is the place where surgeons and obstetricians meet. At least it depends which direction you're coming from. If you come from the front or behind, you're a surgeon. If you come from the center, you're a gynecologist. So when it comes to intervention for obstetric fistula, we need people who have got skills. So there's an element of skill-based training, and also what we call fistula surgeons. So you shall hear them from the panel, and also community awareness as well. But also reintegration efforts so that they come back to their normal lives. So we commend these joint efforts by the government and partners and development partners. We are lucky to have funding from different sources. And back in the years, there was national fistula program in this country, and now I know there's a Tanzania Obstetric Fistula Surgeon Association. All those are efforts, and the focus has been improving services to make sure they are available through strengthening healthcare workers' capacities, but availing surgical equipment, and to sponsor women to go for treatment. So it's all donor supported, and actually is other private sector also support this. So the reintegration, we as Amref, our services have been ranging from community mobilization, supporting treatment, but also reintegration. And they're so like bringing holistic approach that is to ensure that we have this continuum of care and bring her back to life. That includes also having income generating activities and the like. So currently we are recording we have supported training of at least 191 healthcare workers. There's no a single mention of obstetric fistula. You start from the first page to the last page. Plan 1, plan 2, the same. What can we do? Because this will also influence resource, it will also influence resource allocation, even budget allocation. Our health sector strategic plan 5 that we are using now is not even mentioned. Yes, we mentioned all other obstetric issues, maternal health issues, but obstetric fistula is not being mentioned as a disability or injury that a woman would get in the process of obstetric labor or anything of the sort. So again, in the surveys, that's why we're missing data. We could also use this opportunity of doing TD, the Tanzania Demographic Health Surveys, to have at least information about occurrence of obstetric fistula. So it's our plea that we need to consider, to push, to make sure that we elevate the level of recognition of obstetric fistula. It's a problem, it's happening. It's cured, of course, but there's no resource, deliberate resource allocation apart from donor-supported efforts. And we think it's possible if we integrate within the maternal health intervention, but also other aspects. We understand that it's a teamwork, and also our surgeons are supporting it, but also we request that the currently formed Directorate of Maternal Health and the Ministry of Health also consider it as one of the major components within the ministry, together that works together with the DCC, this curative unit that is already accommodating the fistula. So to conclude, let's make a fistula part of comprehensive reproductive maternal health intervention. At antenatal services, let's talk about it. When talking about birth preparedness, early booking to the antenatal, let's mention also you will prevent occurrence of obstetric fistula if you go early to the services. Budget allocation, the same.
So thank you very much. I would like once again to put our hands together and thank Dr. Flo for this. Okay, so after hearing from Dr. Flo, now I would like to welcome our speakers. We have 4 speakers, and I would like to welcome the first one, who is Gaspari Misungwi, who will give us an overview of the Fistula project, which has been implemented by Amref for quite some time. So let's put our hands together as Mr. Misungwi comes forward for giving this presentation. It will be very brief. Gaspari Misungwi is a project manager for Fistula project, which is being currently implemented in Geita and Mwanza regions. He is a development professional. He has extensive technical and managerial experience for more than 10 years in development sector. Gaspari holds a bachelor degree in population and development planning, and he's currently pursuing his master's of project management at Open University. And throughout his career, He has been engaged in project management, especially in social and behavioral change, education, advocacy, and community engagement program. So he's a technical expert in designing, facilitating, documenting, monitoring, and evaluation of health and non-health related intervention. He has participated in a number of business development programs, and he has a commendable knowledge and skills in working with the underserved population, including women, children, and adolescents. And as I mentioned, currently he is working with Fistula clients. He has good stakeholder management for effective relationship and promotion of cross-functional collaboration and partnership. He's very passionate working with women, and especially women with devastating challenges like fistula. So let's put our hand together to welcome Mr. Gaspar Msindi. Karibu Gaspar, and please, very brief. You have only 5 minutes.
Thank you. Thank you so much, Dr. Serafina, our moderator, for the opportunity. And before I continue the presentation, the brief presentation of the project, I just want to really thank Dr. Florence, our keynote speaker, for eluding all the points or the marks regarding our project. She has tried to cover almost all of the project. She's like a project manager. She did a wonderful presentation. Thank you so much, Dr. Florence, for the presentation. You are about to create my presentation. So we really appreciate that. So, good evening.
Good evening.
So I'll be taking you through the project overview of our Fistula Phase 2 project. The project, it's a 3-year project which is focusing on empowering women with obstetric fistula through treatment, psychosocial support, and livelihood opportunities. It is a project which is funded by RMNCAH. The project covers 2 regions. Currently we're working in Mwanza, in all 8 districts, and also in Geita region, where we cover all 6 districts. The project builds upon our experience in pilot phase. The project initially started with a pilot project which was implemented in Magu district, where we did a wonderful job, as alluded by the country director, our keynote speaker. We did also the first phase, where we also had remarkable achievements, as they have been alluded by the previous speaker. This project aims to improve the health and socio-economic status of women who have suffered from obstetric fistula in Mwanza and the Geita region. We have partners in this project. We work with partners. We have the government, whose role is very clear. It's all about supervising, coordination, and also providing technical support to the project. We also we sometimes use local radios to air fistula messages to the public. So, because I'm not using a projector, I'm not sharing my slide. We have also a project implementation model where all the partners have a role to play in this project. It's a very nice model where we work tirelessly to ensure that we reach and identify the fistula survivors from the remote areas where we get them, and then refer them to Uganda. So we have our community component as well, where we work with the fistula survivors. We work together also with the fistula ambassadors to ensure that these women are identified and reached to Uganda for treatment. So that's all from my side. Restoration of smile and the dignity of women who have suffered from obstetric fistula. This is a responsibility of everyone. Everyone is needed in the game to ensure that we address this devastating child death injury. Thank you so much, Chair. I beg to submit.
Thank you so much, Gaspar. Please have a seat. Yeah, so I really appreciate Gaspar for giving us an experience of the project that we have been implementing as a fistula treatment project, but he has also mentioned the different partners that we are working with. To start with, I would like to ask some few questions from Dr. Msafiri. If could you, Dr. Msafiri, share with us the policy environment of fistula and the key milestone that the country has made throughout the journey in supporting obstetric fistula. And you will also share with us the areas that needs to be strengthened to end the obstetric fistula in the country. Please, you are welcome.
For years, we have been repairing the fistula services without having a national document. But in the last year, in the year 2022, we completed a guideline for fistula services, and a few copies have been distributed to you. And this guideline was disseminated to the regional medical officers about a month ago. And we hope by having this guideline will guide us in the course of delivering the fistula repairs. And the milestone that have been made with regard to fistula, we are aware that we have improved a number of issues. We have increased the number of CMOC centers, which means we think in future are going to reduce the number of obstetric fistula, but also we have in place the referral system, the MMAM, which also we anticipate that in future could contribute in the reduction of the obstetric fistula. And at present we have about 5 facilities that are conducting fistula repair, and most of them they are either owned by CSO or place-based, and we have only one public, which are in Billy National Hospital. We have the Bugando Medical Center in the Lake Zone. We have the Nkinga in Tabora region. We have Matenta Africa in the Arusha region. CCBRT in Dar es Salaam. But plans are underway that to include more facilities that will be providing the fistula repair. So this, we hope that by then this will give opportunity for more repairs to be conducted within the country. But despite this achievement, there are some of the issues that we think probably could be dragging us behind, because the number of fistula being repaired here ranges from 800 to 1500, which is about 50% of the fistula cases that here are being diagnosed. So here we have a backlog of 50% of fistula being repaired. But with this also, from the hospital that are conducting the fistula repair, they are reported that we have now increasing incidence of the iatrogenic fistula. So now this is a problem. While we are improving the maternal services, but now another problem has been now created.
Okay, thank you very much, Dr. Msafiri, for giving us the policy overview of fistula and the journey that we have taken in eradicating fistula in the country and the future plan. Can we put our hands together for Dr. Msafiri? Thank you very, very much. Now I would like to take this opportunity to welcome our second speaker, who is Dr. James Chapa. And Dr. James Chapa, as I mentioned, he is a surgeon, an obstetric and gynecologist, but he's also a fistula surgeon and a figure accredited fistula surgery trainer. He's also a public health specialist, but he's also currently a president of the Association of Fistula Surgeons in Tanzania, and he's a member of advisory group of FIGO, Fistula Training Initiative. So I would like now to ask some few questions from Dr. James Chapa. Dr. James Chapa, could you tell us your experience in managing these fistula clients and the trend of fistula from your experience, and what are the success rate for the fistula treated cases?
I don't know if you remember, but I used to attend every case of surgery he used to perform at Muhimbili when I was doing my FA degree. But in the room we also have other surgeons. They are not practicing, of course, Dr. Makuani, Dr. Mzee. But I also have 2 surgeons from Bear Referral Hospital, and Bear is also doing fistula surgeries. It was not mentioned, Dr. Rebecca and Dr. Delphina. Yeah, Dr. Serafina, being a fistula surgeon is a tough assignment. And it's a tough assignment because we are dealing with clients that have no life. They have no physical life, they have no social life, they have no emotional life. So literally these clients, it's like they are dead because they can't associate, they can't move around because they are ashamed of urine leakage. And of course, they are living a life of shame and misery. And this is because of their condition, that they are leaking stool or urine because of the abnormal communication that they are having between the vagina and the bladder, or the vagina and the rectum, which make them always uncontrollably leak either urine or stool. And in the process, they get isolated, as I said, they get ostracized, they get stigmatized, and therefore they are not living. So our task as fistula surgeons, of course, and other teams that are taking care of this patient, is to bring them back to life. That is why I said it's a tough assignment, because bringing someone back to life is not a joke. So working as a fistula surgeon, I've seen a lot of changes, and one of the biggest change is now the change of pattern of fistula. We used to see more of ischemic injuries causing fistula, but now we are going in the direction of iatrogenic fistulas. If you look back 10 years ago, only 10% of fistula cases that were treated in treatment centers were ischemic, were iatrogenic fistulas. But as we are talking now, with the data that we have at CRT, which is the biggest provider of fistula care services in Tanzania, the iatrogenic cases have risen to 43%. So of all the cases that we are seeing at the CRT, 43% are iatrogenic cases. And if we look at where these injuries occurring, majority are occurring in district hospitals, of course, and in health centers. Very few cases are coming from zonal and national hospitals, where you find there's senior surgeons working there. So there's skills. But also, if you try to see what are the risk factors for injuries, for visceral injuries to occur, one of them is adhesions. But 65% of these injuries occurred in a woman with a first surgery. So we expect in a first surgery the pelvis to be clean, to have no adhesions, unless this patient has either endometriosis or pelvic infection. But otherwise, we expect the surgery to be not that difficult for a skilled person to cause an injury. So if an injury is caused in a clean pelvis, most likely there's an issue with skills. So we also need to look at this area. But there could be other reasons, like maybe the working tools. If you operate with a blunt tool, there's a very big chance of causing an injury. But also if you are working in a dim light, you can see properly your area where you operate, there is also a chance of causing an injury. So we really need to see what is the issue so that we can intervene and prevent the alarmingly increased rate of iatrogenic cases. But there is also positive changes in terms of awareness. Now more people, the community is now more aware of what is fistula. And this is why if you look at the data for the first half of this year, you can see there's a very big reduction in terms of time from this woman has an injury to the time that this woman gets treated. It's now 3 years. It used to be 7 years previously, an average time between injury and repair. So this is, we think this is due to improved or due to the fact that many people are now aware of what they should do when they have a fistula. But also, I have seen an improved surgical techniques. We have new techniques that have really improved the outcome. If you look at the same data for the patients that we have operated from January to June this year, 595 women were operated in these fistula centers, and among those, 563 women got their fistula closed. So the closure rate was 95%. But among these, 523 went home dry. So the dry rate was 92%. So you can see there's a very big improvement. Of course, even when you compare with what the standard is in terms of outcome of repair, because with WHO, the closure rate should be at 80%, 85%, and a dry rate of among the closure, the closed cases should be 90%. But we are at 92% dry rate and 95% closure. Thank you very much.
Thank you so much, Dr. James. I think as you have alluded, you have actually shared with us a lot of technicality around fistula management, but you've also shared with us challenges that goes with this fistula management. But then you mentioned something so alarming, which is a rising of iatrogenic fistula, which is critical, and of course it goes with competency among healthcare workers, especially the surgeons who are dealing with the gynecologists who are doing the cesarean sections. So thank you so much, Dr. James Chiapa. Now I'd like to go again to Ms. Faith Mary Kindo. I have some few questions for you. Ms. Faith is a regional social welfare officer, as I mentioned, and she is also she has BA, Bachelor of Art in Sociology and Psychology at University of Dar es Salaam, but she's also pursuing Master of Social Work at Open University. Ms. Faith is a TOT on mental health, psychosocial care and support services, and she's actually currently working in collaboration with our project, which is implemented in Mwanza, but supporting these women who are survivors of fistula. So I would like really to ask some few questions related with the work that you have been doing, especially in collaboration with this project of fistula. And I would like you to share with us your experience in working with these survivors as you visit them, and why do you think the psychosocial support that is being provided to these women is very important. But I would also like you to share with us some of the best practices and the challenges.
I personally was able to meet women who had denial. They could not believe that they had a fistula, which was curable, so they could lock themselves in, believing in other beliefs that maybe maybe it's caused by witchcraft. And so meeting them physically and talking to them, or showing some champions who are healed, who are they went through the surgeries it was one of the things that really helped them to recover and finally accept treatment. But also we met fistula clients who were experiencing abuse. I remember in Kwimba, we met a woman who was severely beaten by the husband because she was, when you are sick and when you are not feeling well, sometimes you become aggressive, sometimes you become emotionally, you become stressful. So the husband could not cope with her. The husband could not provide supportive environment to help her heal. So instead, he was just beating her, and she even got some scars. So when we arrived there, we talked to her about it. When she opened up about her experiencing GBV, it was not the right time to take her to the hospital and do the case management. But finally, she was able to undergo treatment, and we also talked to the husband. And right now, as I speak, she's in 2nd trimester pregnant, so the family is now at peace. So among things that we noticed is that fistula clients do not only have issues of psychology or going through mental issues, they also get abuse sometimes from their family members. We also had a client in Magu who herself was doing GBV to other people because she was furious all the time because she did not accept the disease. So it was also a time to conduct case management on GBV, to assist her building resilience, stress management, and coping skills. And finally, she was also able to go for treatment. But again, we also had clients who opted for substance use. For example, an older woman in Magu, she was very old, she was like 52 years, but she was using alcohol excessively. Even in the self-care, she forgot all about it. She was super shabby. So we went there with the Amref team, we talked to her, and with several sessions, we were able to see change, and she accepted the treatment. So mostly we noticed that fistula clients, they have so much stress, and sometimes they're abandoned by their spouses. The separation level was almost 60% among the families we visited. And the funny thing is when they get treatment, the husbands come back. So it's really interesting how husbands are. Yeah, so that is it. But also the income, as the previous speaker said, most of the families that we visited were a little bit poor. Their living conditions were not very good, and I think that somehow was influencing the delays to reach to the healthcare centers. But also we noticed, as he said, some clients had the disease for a long time, like the historian said. Some people had fistula for 5 years, 6 years, and have been attending clinics to our healthcare facilities. So we also noticed there is a gap of knowledge of screening for fistula, because a person could go for treatment with other diseases, but the practitioner could not screen immediately or know that this is fistula. So I think that was also a gap. I'm now talking about the challenges, but also male participation or involvement was very low. We could plan for a session at the family level, and you only find women attending there. Men were not around. But also after the operation, the doctors mentioned that client has to stay for 4 months, not making love, not having sex. But sometimes they fail to do that, and so it leads to repetition of surgeries, and that is more traumatizing to these women. So I think on the issues that you need to work on is involving more males on the fistula issue, so that they produce conducive and supportive environments which will assist these ladies to heal fast. Yes, and another issue, I think the community is not very much aware of fistula, because so far we still have women who are looking themselves inside. We also have women who are diagnosed with fistula, but they go to other medical care, they don't go to hospitals, they believe in witchcraft, and labeling of these patients. They call them, they're cursed, they bring bad luck to the families. So I think we need more education, and I was thinking maybe if we print small posters or use social media where everybody is out there, like Instagram, Twitter. I think also, I remember the other time we used to hear malaria, sio kila homa ni malaria. That thing was just ringing. So if we also create some jingles about fistula, maybe everybody will come out. But the very first and the most important thing is to address the stigma and misconceptions. Because these people are hiding inside because they know when they open up, they will be judged. Maybe they were prostitutes, or maybe they're just cursed. So if we address the stigmas and myth around there, it will help people to come out and express their feelings. Yeah.
Thank you so much, Faith. Can we give a round of applause? Now I would like also to welcome our ambassador, Mr. Samuel. As I mentioned, Samuel is coming from a village called the Busenge Buliaheka ward in Buchosa, where he works as a community health worker, but also as a fistula ambassador, and he's been selected by the community as a volunteer. But he's been really assisting. Is assisting this fistula, looking for fistula clients in the community, and also he provides psychosocial support, referral, data collection, report and record keeping as a community health worker. So let's again put our hands together to welcome Mr. Samuel. Thank you very much. Ningependa tunajadili mjadala juu ya masuala ya fistula na kazi ambazo zinafanyika kwenye jamii, na wadau waliopo hapa wangependa kujua kwa uzoefu wako kufanya kazi na katika ngazi ya jamii na jinsi ambavyo tunawasaidia hawa mama ambao wana fistula katika jamii. Unaweza ukatushirikisha uzoefu wako, na je, shughuli zako unafanyaje na unakutana na changamoto gani katika utekelezaji wa hizo shughuli? Karibu sana Mr. Samuel.
Asante Fina. Nashukuru kwa kupewa nafasi hii. Mimi ni balozi wa fistula kama nilivyosema. Uzoefu ninao, na walionipa uzoefu ni Plani International, mama na mtoto, CCBRT, waibua wale wa mdomo wazi. Amref wamenipa uzoefu kwa kuwaibua wahanga wa fistula. Kazi ninazozifanya kubwa kuelimisha jamii kuhusu fistula, dalili zake. Jambo la pili, ninapowaibua ni waelekeze ni wapi wakatibiwe, ni Bugando. Jambo la pili, ninawapa barua ya rufaa ya kwenda kutibiwa Bugando. Amref wanatoa nauri na kuwapa wahanga na kuwapeleka hospitalini. Ninawashukuru sana. Baada ya kusema hayo, mafanikio ya kuelimisha jamii. Nimeelimisha jamii kuanzia mwaka 2020 hadi 2023. Nimeibua wahanga wa fistula 28 na tayari wamekwisha kutibiwa. Nimeibua mdomo wazi watoto 37 na tayari wamekwisha kutibiwa. Si hivyo tu, Amref kuwasaidia wakina mama kwenda kutibiwa hospitalini, bali Amref wanayo kazi nyingine ngumu na nzito kwa kuelimisha jamii kuhusu fistula. Na hawa wahanga ambao nimesema 28 wameenda mafunzo ya ujasiriamali, na baada ya kwenda mafunzo wamepewa zawadi. Yaani walichagua kitu wanachotaka wenyewe. Kama wanataka biashara ya vifaa, bidhaa, wanataka ufugaji, na kweli wamepewa. Na baada ya kupewa, niseme mafanikio yao ya hawa waliopewa. Watu 6 waliopewa mbuzi na sasa wamefikisha ng'ombe 1 na mbuzi 3. Waliopewa biashara vitenge na nafaka, watu 4 wamenunua ploti na sasa wana taratibu za kujenga nyumba. Kuna mmoja ambaye amenunua ploti na amejenga chumba kimoja na sebule, tunaita slope ya chumba kimoja na sebule. Na Dr. Dara namshukuru sana, ni mashahidi wangu, anakwenda kuhakikisha kufika kwa wale ambao mpiga hatua, nikimuita anaitika. Changamoto ambazo tunazo kule vijijini kubwa ni wakina baba hawataki kushiriki kwenye mafunzo ya fistula, na wakina mama wanapopata fistula wanawatelekeza, wanakimbia visiwani, Lakini cha maajabu, sisi wanaume baada ya kupona tunaanza kurudi polepole, tunaacha nyumba zile ndogo za visiwani, tunarudi tena. Na pia wakina baba wale wanaposikia kwamba tunaleta leo wamechagua kama ni mbuzi au ng'ombe, tunakuja kukabidhi kwa mhanga, wakina baba tunawakuta wapo, lakini wakati wa kuelimisha wanakuwa hawapo. Hiyo ni changamoto. Changamoto ya pili ni mila potofu. Watu wanadhani kwamba watapelekwa wake zao Mason, wanakuwa hawaamini kabisa. Changamoto nyingine ambayo ipo ni imani potofu, ambayo nimesema kwamba mtu anatibiwa, baada ya kutibiwa anapewa masharti, usifanye tendo la ndoa kwa mila ambayo umefanya kama ni miezi 3 au 4, lakini wanageuza sasa, wanasema usipofanya kwa miezi hiyo unaugua ugonjwa sijui wa chekelea. Mtu anaanza kufanya kabla ya siku hazijakaribia, tena anapata fistula. Na hao nishawabaini, naendelea kuelimisha jamii ili waondokane na imani potofu. Mtu akitibiwa basi atimize zile ndoto zake za kupona. Jingine, familia kama familia zinanyanyapaa. Mtu anakwenda kutibiwa, anarudi ameambiwa anabeba lita 5, lakini mtu anakuta anabeba lita 20 za maji. Sasa kutoa chini kuweka juu, tayari ile misuli inakuwa bado haijakaa vizuri, tayari anaanza kuloa tena. Nashukuru madaktari wanaohudumia. Kweli ninapotoa taarifa hizi wanasema walete tena ili wajapate matibabu. Shukrani ziwaendee madaktari wote, wafadhili wote ambao wanafadhili hii. Na niseme tu kwamba nitoe fadhila kwa waziri, naibu waziri wa afya pamoja na kabineti iliyokuwepo mwaka jana, ilipatia mwendo kasi, ndio maana kazi hizi nazifanya vizuri. Mwendo kasi wangu umeandikwa Kamongo, yani ile imeandikwa Kamongo kabisa, sasa inateleza kama Kamongo na sasa naenda tu milimani, naenda kweli. Nawashukuru sana na Mungu awabariki.
Asante sana Ambassador Samuel. Asante, tunashukuru kwa kuweza kutupatia picha halisi ya kazi unayofanya, na ni kazi nzuri. So Samuel amesema kwamba amepata nini? Kamongo. Samuel ni ambassador, tumekuwa naye kwa kipindi kirefu na alishawahi kuwa recognized na naibu waziri kwa kazi nzuri ambayo anafanya, na aliweza kuzawadiwa baiskeli ambayo ndio wanasema mwendo kasi kwa ajili ya kufanyia kazi. Kwa hiyo tunamshukuru sana Samuel, naomba tuendelee kumpigia tena makofi mengi. So thank you very much. Now because of time, I think I would like to open up the discussion and welcome some few questions. We'll only have one round of questions and comments.
Umesema kwa zamani ilikuwa ischemic fistula. Sasa kuna trend ya kuongezeka kwa iatrogenic fistula. Sijui kama come across au kuna uchunguzi, study au data yoyote kuhusu relationship ya fistula na FGM, female genital mutilation. Kama tukafanya study hiyo, kama ipo ningependa kusema. Na kwa sababu unajua katika watu makabila yanaoishi katika Rift Valley, bonde la Ufa, wengi wanafanya hiyo. Wengine wanasema female circumcision, wengine female genital mutilation. Mimi nime experience kwa sababu nimekaa Dodoma kwenye nimepelekwa pale as an obstetrician gynecologist wa Central Zone kukava Dodoma na Singida in 1984. Sasa makabila ya pale Wagogo, Wasandawe, Wanyaturu, anyway, this is wana practice. Sasa hiyo kidogo wa experience kusema. Ya pili, mambo ya psychosocial. Nakumbuka mimi nilipokwenda for clinical attachment ya Vivi in 1995, nilikwenda Addis Ababa Fistula Hospital. Kwa hivyo nilikuwa attached kwa Dr. Catherine Hamlin, ndio mwasisti na yeye ananiasisti. Kwa hivyo nika refine technique ya VVF repair kwake. Akawa anasema kuna hawa watu wa VVF, wengine wanaona bora angekuwa kipofu kuliko kuwa na VVF. Kwa hivyo si
nilitamani kuuliza kwa component ya mental health and psychosocial support. Nilitamani kujua referral pathway inavyofanyika kwa wale clients ambao wanahitaji more specialized care, maybe kwa psychologist au psychiatrist, na kama kuna data ambazo za referral ambazo mmeweza kufanya ambazo mnaweza mkashare kidogo.
Wanasema kinga ni bora kuliko tiba, na kwa maelezo ya hizo namba za heterogenic it's so high, na kwa maelezo ya daktari pale wa wizarani kwamba 50% hatuwafikii, manake tunaweza kwa mwaka tunaacha 100% za nyuma nyingine, wanakuwa wengi zaidi. Sasa nilikuwa nauliza nyie madaktari wa fistula specifically, na taratibu za kuwajengea uwezo hao ambao tayari tumewaloketi kwamba kuna shida, labda ili kuzuia sasa ndio usiwapate hao heterogenic katikati ya mafunzo yenu, kwamba ni mko target tu kwa ajili ya skills za kutibu fistula au pia na kufundisha skills za kuprevent fistula?
Kwanza mimi nataka niwapongeze Amref kwa kazi nzuri ambayo wanaifanya pamoja na wadau wote kwa kuend fistula, hususani kwa kule Mwanza. Mimi nilikuwa na overview mbili na question moja. Ya kwanza nianze kwenye questions. Dr. James alitaja alitaja zile data za fistula rate na kwenye prevention, hususani kwa masuala ya treatment. Sasa nilitamani kujua at least age category, what are the most victims hapo kwenye upande wa obstetric fistula, lakini pia kwenye swala la, kwa sababu kuna prevention and treatment. Kwenye prevention we know there's most of causes of obstetric fistula. As a young people, we are using to teach people about adolescent reproductive health. So how do we link those interventions, since cause the early marriage, teenage pregnancy, it's among of the causes of obstetric fistula. So how do we take that, especially with the social psychological support? Yeah, how do we link those interventions, since we needed to make sure that there is a teenage pregnancy, and the most of them it's occur on the scattered areas. That means in the villages. So how do we prevent them, since there is no quality health services on those areas? So those are my questions. By the way, I'd like to congratulate you.
This is really really important work that is so silent like the disease. My request is that it is so like there's such good work happening, and every fistula is a testimony of a mismanaged patient. Because even a teenager should not get a fistula. If they were treated properly, it should not happen. For a medical professional to cut a ureter, also it should not happen. My thinking is, one thing that has really worked in Tanzania is the Zoom maternal audits, my request is for consideration of every fistula case to be audited. And that will raise awareness among the doctors, among everything, because what is surprising is there's still a secrecy. So I think sometimes as health professionals, we also don't want it to be. So we're not talking enough about it. So I really would like for consideration the audit of all fistula cases so that it becomes really widespread and even people will begin to.
Studies ambazo nimeziona nyingi ni they are just observations. Lakini sija kama cross analytical study kuonyesha uhusiano. Lakini FGM kama FGM yenyewe directly inaweza cause fistula, especially urethral fistulas kama FGM was that extensive. Lakini pia kwa sababu if the FGM is extensive it can cause scars. Kwa hiyo during delivery inaweza kusababisha fistula when the perineum is stretching kwa ajili ya kuruhusu mtoto kupita. So there is an association in terms of observations, lakini there is no analytical study that ambayo mimi nimewahi kuiona ambayo inaonyesha a clear association between FGM and fistula. Swali la Dr. Nyasato, prevention kama tunafanya, yes. Tuna train watu zaidi tu ya kutrain kuwa surgeons, lakini pia tunawaonyesha namna ambayo wanaweza waka prevent fistulas. Sisi BRT ni training center, FIGO accredited training center. Tuna train fistula surgeons. Unfortunately, wengi ambao wanakuwa trained sisi BRT wanatoka nje ya nchi. We are training more foreigners kuliko Tanzania. I think kwa Tanzania tumeanza kutrain 2014, tumetrain only 2 Tanzanians out of 26 trainees ambao wamekuja kutrain CCBRT. So prevention ni one of the component ya training ambayo huwa tunawapatia. Lakini hii issue ya iatrogenic fistula kuongezeka, I think tunahitaji kuendelea kufanya mentorship, kuendelea kufanya coaching kwa wale junior surgeons kule chini. Nadhani hii ni kazi pia ambayo wizara inaweza ikahusika moja kwa moja. Na of course kwa mfano kwa mwaka huu ukiangalia unaweza ukaona ni mikoa gani ambayo imeathirika zaidi. Of course Dar es Salaam inaongoza ile half ya kwanza ya mwaka. Dar es Salaam imekuwa na wagonjwa wengi zaidi labda kwa sababu ya awareness. Watu wanakuja na of course kuna CCBRT ambayo wagonjwa wanaenda pale wanapata kutibiwa. Mwanza ni ya pili, Tabora ya tatu, ya nne nadhani ni Shinyanga. Hiyo mikoa hapa. Na of course kuunganisha labda na ile swala Dr. Mohamed, hii sio mikoa ambayo kuna FGM sana, lakini kuna fistula zaidi. Kulikuwa na issue ya age categories, nadhani kama nilisikia vizuri, average age ni 31 years ya wagonjwa ambao wanapata fistula. Na wengi wanaathirika of course ni hapo kwenye hiyo reproductive age 20 to 40 years ndio kuna wagonjwa wengi sana. Teenagers wapo lakini they are few compared to hawa multiple. Kwa hiyo fistula haichagui age, at any parity mtu anaweza akaipata.
Kipindi cha nyuma tumeshapata data kiasi gani za ambao tumewapa referral kwenda kwenye madaktari labda wa afya ya akili. Kuna vitu viwili, kuna mental illness na tuna mental problems. Wagonjwa wengi wa fistula wanaishia kwenye hiyo level ya mental problems. Yaani unakuta wakiwa diagnosed clinically hawawi na mental illness, lakini wachache ndio unakuta wanafikia mpaka hatua ya kuwa na mental illness. Kwa hivyo hawa almost 70% wanakuwa na mental problems kama hizo anxiety, unakuta wana depression kidogo lakini sio ya highest level. Unakuta wengine wamepata hizo low self esteem. Kwa hivyo through psychosocial support wana recover kidogo. Lakini nakumbuka mwaka jana au mwaka mwanzoni kuna mmoja yule aliyefanywa operation kalbia 5 ambaye alikaa na sijajua biologically tatizo ni nini. Yule alikuwa anaelekea kwenye mental illness na tuko naye karibu sana na nafikiri iko mbioni kupata referral kwenda Uganda kwa ajili ya mental check up. Yes. Kwa hivyo wengi wako kwenye mental problems kuliko mental illness. Sasa hizi data za ndani wanazitoa kama mali kwa sababu wafanya wako kwenye eneo tu la psychosocial. Yeah, lakini next time I guess tutakuwa na data mkononi.
So umalizie na recommendation yoyote ambayo unaitoa?
Recommendation ni elimu. Kusema kweli elimu ndio naona bado. Tumefanya kazi kubwa, tumetoa tunafanya kazi kupitia redio pale Mwanza, Radio Kwizera, tunatoa elimu mara kwa mara, lakini bado tuna watu wamejificha. Lakini bado tuna wababa ambao wanakimbia wamama kwa sababu tu wana fistula. Bado tunawanyoshea vidole wahanga. Kwa hiyo nafikiri elimu bado inatakiwa itolewe sana, lakini pia kuwaweka karibu watu wa fistula. Lakini nilisahau kusema kitu kimoja, mradi wa fistula una support ina ile component ya startup kit. Kwa sababu kama mnavyofahamu wenzetu wenye ugonjwa wa fistula wanakuwa wameji-exempt kidogo kwenye masuala ya kijamii. Hawaendi misikitini, hawaendi kanisani, hawajihusishi na shughuli za uzalishaji kwa sababu ya kuogopa wakati mwingine kuleak urine kwenye public. Kwa hiyo unakuta kwa kipindi kile anaumwa, anakuwa amejifungia. Kwa hiyo mpaka aje kutibiwa unakuta economically ameshuka sana. Kwa hiyo mradi huu unawasupport startup kit kwa maana ya 1,500,000, lakini hawawapi cash, wanaitumia kuwapa mifugo, kuanzishia maduka. Na mimi binafsi nilitembea kwenye baadhi ya familia nikakuta kwa kweli mama ametibiwa na ameanzisha biashara kadogo pale, ameanza kama ku step up kidogo. Kwa hivyo hiki kitu nafikiria ndio kikubwa sana, kwa sababu unapompa mtu msaada wa kisaikolojia umemsaidia na matibabu, lakini sasa anaanzia wapi? Kwa hiyo unapokuwa mnampa kianzio, nafikiri hiki ni kitu ambacho mnakuwa mkiendeleza ili yule mama aweze, kama mnavyojua wakati mwingine anakuwa kwa bando ndio peke yake na watoto, inakuwa anapata nafuu kidogo ya kwamba anajua kidogo nitafika.
Fikiria kuwa labda tuwe na utaratibu wa kufanya audit. Tumepata kesi ya fistula. Hili jambo labda linawezekana, jambo linahitaji nguvu ya pamoja ya serikali pamoja na wadau ambao tumekuwa tukisupport huduma ya afya ya uzazi. Sababu fistula kama fistula ilivyo bado inaonekana kipaumbele bado iko chini. Inabidi tuiamshe iweze kuwa ingizo kwenye kipaumbele. Sababu ukiona kitu ambacho hata finance yake inategemea donors, maana kwa bado kipaumbele akijawa japo tatizo lipo. Kwa hiyo inawezekana kukawa na mkakati kama ambao Chapa aliongea kwamba tunafikiria kutokomeza fistula by 2030, lakini ndio mkakati madhubuti. Kwa hiyo inawezekana kuwa na kufanya audit. Pendekezo yapo mengi ambayo yanaonekana yapo kwa sababu hatuna takwimu au hatuna tafiti ambazo zimefanyika. Kesi ya incidence kubwa ya iatrogenic, lazima akademia na watafiti waingie site kwa ajili ya kufanya tafiti kwamba kwa nini iatrogenic na sio ischemic, na kwa nini tuna simple kusenda za kutosha. Fine, tutemea kwamba hali iendelee kuwa nzuri, lakini badala yake badala kuwasaidia tunaongezea matatizo. Kwa lazima tafiti ndio la kwanza ambalo jambo la msingi lifanyike. Lakini tafiti hiyo pia iweze kuangalia kwamba tuna fistula surgeon tayari wamekuwa trained. Lakini kwa nini wanaenda baadaye labda wanaacha, kwa nini wana refrain kuacha kuendelea kufanya hiyo kazi? Hapo inawezekana kwa sababu procedure inachukua muda mrefu. Ndio maana mwisho wa siku wanaona bora akimbia akafanye CS ambao kwa siku anaweza kufanya nyingi zaidi kuliko kufanya fistula repair. Kwa hiyo kuna vitu vingi ambavyo inabidi tuweze kufikiria. Lakini la tatu nadhani kuna muhimu ambalo mkini huduma ya jamii ambao ni jambo la msingi. Case finding na linkage. Kwa lazima tuwaibue wagonjwa wengi na tuweze kuwaelekeza kwamba mahali fulani huduma hizi zinapatikana. Kwa lazima tuwekeze zaidi kwenye kuwajengea uwezo umma, raising awareness, lakini pia case finding na linkage. Mwisho wa siku sasa hao ambao wameendelea kukaa kwenye jamii na fistula kwa muda mrefu waweze kutibiwa, na tunaamini nadhani tunapoenda kujengea uwezo tutakuwa tukiaddress pia ambavyo issues ambazo zinaonekana kusababisha wala kuwa na recurrence. Kwa pamoja pia na kuwa na kufanya advocacy kwa ajili ya male engagement. Maana bila kuwa na male engagement bado inawezekana kufanikiwa kama.
Was number of health facilities for providing fistula repair. We've heard from the ministry that we only have 5 which are facilities specific for providing this fistula repair. So it is good that the government is planning to increase, but we want to just hammer that this is important to have. The country is big. To have only 5 centers for fistula repair is a very small number. We've also heard about fistula team that they are lacking skills like nurses, surgeons, anesthetists. So we also need to increase number of this team, especially building their skills, training them, so that we have a number of teams that will be supporting the fistula repair in our health facilities. The other thing that we have gathered is capacity of healthcare workers for diagnosing fistula, and we've heard the story that a fistula patient can go even several times to the health facility and fail to be diagnosed. So we need to capacitate our healthcare workers to be able to diagnose this fistula. We've also heard about community lack of, myths and misconception within the community, and that's the area that we need to do more community awareness on the fistula. But also we've heard about male engagement, that men are shying away from the issue, supporting the women who have fistula. So we also need, in raising awareness, we also need to engage men so that they are also part of this journey and they support these women. The other area, from the policy level, we have talked about fistula data, which we are not available, and so it is important to have these data collection, proper data collection for fistula, and link them perhaps into the HMIS. The other area is, which is very important, is having a strategic plan for eradication of fistula. As we target or we focus to have fistula eradicated by the year 2020. So it means that we need to have a clear strategic plan that will guide us as a roadmap towards year 2020 to eradicate fistula in the country. But also we have heard about budgeting issues. So the government, fistula management is purely dependent on donors. So we need to allocate funds. The government has also to include into the budget fund allocation for fistula management. I have heard a lot of questions about any kind of research that have been done or any kind of data. So I think it is also important to include fistula as a research, in research agenda of the country, but also engaging different multi-stakeholders. So with those few recommendations or some key take-home message from this discussion, I would really once again like to appreciate and thank our main speakers, but also I would like to thank you for your active participation and for asking questions, but also giving some of the recommendations through this discussion. So to this end, I would like perhaps to welcome again our country director. If you have anything, just to, as we are winding it up our discussion, just say something to our audience.
Unaweza kuta tunasimama sisi kwenye podium, lakini kweli kuna watu ambao wanafukuzana na hii kazi day and night. Mmoja wapo ni Magdalene. Anafanya kazi na Gaspar, kutana na hao wenzetu wanaingia ndani sana. Lakini napenda kuwashukuru pia madaktari, na inapofika swala la uendelevu, sustainability, ni kweli tunahitaji kuwa na framework za sera na za mikakati ambayo ina kwa makusudi kabisa, deliberately mentioning obstetric fistula ending to eradicate, iwe kwa makusudi. Na hata katika takwimu zetu tuzitamke, tuseme kuna matukio kiasi, sibakie tu kwenye ngazi ya miradi au kwenye taarifa za kihospitali. Kwa nafikiri nao tutengeneza ripoti, tutengeneze hivyo, na tunaomba pia wenzetu ambao kwenye practice, waganga wakuu, muweke kama ni issue, ili kuwe kuna budget ya makusudi kabisa, hata siku ambao donor anakuwa wapo, lakini hiyo huduma inaweza kupatikana. Kumbuka yule mama ambaye muda wote amekuwa akienda antenatal care, akaenda obstetric care, eti tu kwa kuwa sasa amepata fistula na wengi wamekosa watoto, basi ile sera ya huduma bure inakuwa imekufa. Anatakiwa ile sera ya huduma bure imshike pia huyu ambaye anapata fistula. Isiingie kwamba lazima apate hela itoke kunao. Iwe sehemu ya continuum of care, comprehensive care, holistic care ya mama mjamzito, whether anapata mtoto, anapata fistula au amekosa, awe entitled kuwa regarded kwenye sera nzima ya mama na mtoto. Asanteni sana.
Fistula inazuilika kabisa.